Thank you. Our speakers are here to discuss the case, and Dr. Kolomansky.
Okay, good morning, dear colleagues, and thanks to the organizing committee for giving us the opportunity to present the case. So this is a 68-year-old lady who first came to our clinic like a year ago, and this is her past medical history. At that time, she complained of weakness and fatigue, as well as some easy bruising that was actually evident on physical examination. On CBC, she had the macrocytic anemia with the hemoglobin of 8.1 grams per deciliter. She also had severe thrombocytopenia with platelet count of around 50%. The white blood cell count was normal. Routine workup for anemia actually was negative, and there were no signs of hemolysis. A bone marrow examination surely was done, and the sample actually was markedly hypocellular, as you can see here. There was no fibrosis, there was some erythrodysplasia, and there was a significant paucity of megakaryocytes, the most of which were actually micromegakaryocytes, and importantly, blast count was not increased. The karyotype was normal, and there were no aberrations on FISH or NGS panels. There was a small PNH clone, though, of 6%, again, detectable on flow cytometry, again, with no signs of hemolysis. So the working diagnosis that was proposed was hypoplastic MDS, according to the 2022 WHO classification, defining hypoplastic cases as the ones having the cellularity less than 25% with no excess of blast. And regarding the risk category, she was assigned to a low risk according to IPSS-R and moderate low according to IPSS-M. So we decided to offer the patient immunosuppression with cyclosporin A, which was started along with a recombinant erythropoietin, and it should be mentioned that by the time she started cyclosporin, she had already become transfusion dependent and also needed some platelet transfusion. But fortunately, after 4 months of therapy with cyclosporin, we did begin to see a response with the rise in the hemoglobin to around 9.9 grams per deciliter, and also a rise in platelet counts to 30 or even 40K. Now, at this point, the bone marrow was reassessed, and the good news was that the cellularity went up significantly, up to 70%. However, the dysplastic changes became even more prominent and involved all lineages. Again, there were no excess of blasts. Surprisingly, though, the cytogenetic studies demonstrated an appearance of 2 separate large clones, one of them having deletion of chromosome 7, as you can see here in the picture. There are 2 dots instead of 4 in the diploid state, and also a clone having an inversion of chromosome 3. So apparently the patient progressed to high risk and was referred to transplant, and in fact she does have a sibling donor and is planned to undergo the procedure soon. Another thing of finding worth mentioning is an evidence for iron overload as reflected by low T2 signal in the liver on MRI scan, along with high ferritin levels, so iron chelation was added too, although the Fraserox is somewhat problematic in combination with cyclosporin in terms of renal function. So these are the questions that we thought might be, or points for discussion we thought might be relevant. So first of all, should we manage hypoplastic MDS and aplastic anemia in adults in a similar manner? For example, adding also ATG. What is the significance of PNH clones? For how long should we administer immunosuppressive therapy in patients who respond? And now, one of the more remarkable phenomena in the course of this case is actually an appearance of cytogenetically adverse clones. And the question is, does it actually result of escape from immunosurveillance as a result of administration of T-cell directed immunosuppression? In that respect, maybe there is a subset of patients who are not bona fide high risk that we might consider an earlier transplantation strategy. And finally, whether iron overload could affect transplant results or outcomes. So thank you, and Moshe.
So,
Which of our experts would like to take the
Well,
first?
I have a go at it first.
Okay.
So when I looked at this marrow, which was shown here, it looked like aplastic anemia to me, and the fact that there was a PNH clone with it, which was significant, 6%, that all suggested aplastic anemia to me. But the only thing against that was the presence of microkaryocytes, and particularly micromegakaryocytes. And if John Bennett were here, he would have said micromegakaryocytes are one of the hallmarks of the diagnosis of MDS. But then, as the patient was treated with immunosuppressive therapy, well, not quite immunosuppressive therapy, was treated with cyclosporin A, which is only part of immunosuppressive therapy. She then has an emergence of monosomy 7. Monosomy 7 itself can also occur in aplastic anemia, as we know. Sometimes it's transitory monosomy 7, it can disappear. But in this instance, it was just monosomy 7 as well as, more worryingly, chromosome 3 abnormality. And chromosome 3 abnormality kind of goes well with the bone marrow trophine, which is hypercellular with lots of abnormal megakaryocytes, which I could see a little bit here. So in summary, I think it is still, in my view, a very, very difficult diagnosis to make hypoplastic MDS, because not only is there overlap between aplastic anemia and MDS, but there is also an overlap between those MDS cases that are associated with, for example, large granular lymphocytosis and all that spectrum of disorders that may or may not be associated with other things. But in the end, if it was a persistent monosomy 7, a persistent chromosome 3 clone, then it's clearly MDS. Now, whether cyclosporin had anything to do with the emergence of a clone is debatable. Theoretically, possibly yes, but difficult to say. So would I transplant this lady with a ferritin of 2,000? I would have liked to see ferritin below 1,000, because there's data to show higher the ferritin, the worse the outcome post-transplant. But given that you have monosomy 7 as well as chromosome 3 abnormality, that's probably the only way the disease can be controlled, stroke cured.
Can we have the last slide on the screen?
Do you want to go next, Lionel?
Is the questions.
Yes, I fully agree with what you said.
Yeah.
And I just want to add something. Right from the beginning, the NGS didn't find any mutation. That is quite unusual in the MDS. Also, even if the outcome was at the end that the patient had probably an MDS, but right from the beginning, I'm not quite convinced whether this patient should be diagnosed as hypoplastic MDS or aplastic anemia. Is it really important, the name of the disease? It's more important to have the good treatment for this patient, and probably for this type of patient, be much in favor to do an aplastic anemia treatment with ATG and all the stuff all together, and then if it's not effective, to go to transplant. But this is just something I wanted to add.
I'm going to completely agree. You know, I think I wouldn't be confident to say that it was for sure hypoplastic MDS, especially with the absence of any mutations. And that sometimes distinguishes the two. They often have fewer mutations with hypoplastic MDS than in general MDS, but they usually have mutations. And I would have treated them exactly the same, probably at her age, with ATG and cyclosporin. I'm not so sure I would have used erythropoietin. I don't find it works well in aplastic anemia. Growth factors don't. The question is, did the new clones emerge as a result of the immunosuppression? We can't know, but we also know that the pathophysiologic mechanism of hypoplastic MDS and AA are quite similar, this immune attack, and it's a pro-inflammatory milieu that may in and of itself promote clonal expansion. And it may be that the clones were there, they just were too low and suppressed. I'd be interested to know what happened to the PNH clone. And the other thing just to remember that in somebody young like this, you need to think about germline causes of bone marrow failure, but the PNH clone being present is sort of like a quick and easy way of evaluating that it's most likely the patient does not have a germline cause. They seem to be mutually exclusive. So I use that in determining in my patients whether or not to use immunosuppression or to wait and do germline testing to see if they have a bone marrow failure. And as for hemochromatosis and stem cell transplant, yes, it correlates with bad outcomes, but there's no randomized studies that show benefit. And there is one study that showed that again, observational, that the initiation within the first 6 months after allo of iron chelation actually improves outcomes, but there's no evidence that it improves outcomes if you chelate pre-transplant.
Okay, thank you.